Okay, we got about 25 people on the line. And we imagine we'll have some more people rolling in, but it is 2:01 and we do try to keep this exactly to an hour. So I'm gonna go ahead and get us started today. My name is Marcos Staffney, Executive Director of the Montshire Museum of Science, and your host today for Health Research Live, COVID-19's impact on rural health equity. Health Research Live is a program developed in partnership with Dartmouth Synergy, the Dartmouth Hitchcock Norris Cancer Center, Montshire Museum of Science, and the Center for Global Health Equity at Dartmouth College. Big shout out to our co-producers, Aurora Drew and Jenna Schuffelbein, who are both in line as well. Health Research Live is a program that looks at various sides of public health research and policy. As the COVID-19 coronavirus is the most pressing public health issue facing our communities right now, we thought we'd bring together the community around this topic. So I'm in charge of changing slides today. And trying there. Oh, I've gone too far. Apologies about that. Here we go. How it works. The program today will feature 4 speakers who will present for about 20 minutes each. Then we'll be breaking up everyone into virtual Zoom rooms so that you can have smaller group discussions about what you've heard for about 15 minutes. And we'll come back together for a broader Q&A that will host the chat feature. The initial speaker presentations and the large Q&A will be recorded and distributed through various social media channels. So just giving everyone a heads up that those sections are recorded. The central sections in small group conversation are not. COVID-19 is impacting every area of our lives. While you've seen coverage of COVID-19 response all over the news, what's it doing with the health of our region's rural populations, and how have they been impacted by COVID-19? While there have been many challenges to our health systems, the pandemic has revealed strengths within our rural communities and health systems. Today, we'll be joined by Ann Sosin and Elizabeth Carpenter-Song, researchers from the Center for Global Health Equity at Dartmouth College, who have conducted a study to examine the impact of COVID-19 on rural communities and health systems. Afterwards, we'll hear from Sally Kraft, Vice President of Population Health at Dartmouth Hitchcock Medical Center, and Faye Homan, a doctor with Little Rivers Healthcare in the Wells River Bradford area of Vermont. So without further ado, Ann and Elizabeth, I'm going to hand it over to you, and just let me know when you need to advance a slide.
Terrific. Thanks so much, Marcos, and thanks to everyone on the line for joining us for this conversation today. I'm Elizabeth Carpenter-Song, and I just wanted to thank Marcos and his team at the Montshire, Aurora and Jenna, and everyone with Dartmouth Synergy and the Norris Cotton Cancer Center. It's really wonderful that we're all here together, and it's wonderful for us to have the opportunity to share some of our recent work with the community today, and we're interested very much to hear your questions and your feedback on our rapid research. Also, big thanks to Dr. Sally Kraft and Dr. Faye Homan for being our partners in this work, and Ann and I would also like to express our deep thanks to the Bristol-Myers Squibb Foundation and the COVID-19 Spark funding at Dartmouth College for generously funding our study. Marcos, could you advance the slide, please? So to give some background and context to get us started, really our main goal in this work was to understand how the COVID-19 pandemic has been impacting health equity in rural Vermont and New Hampshire. And when we use the lens of health equity, we're thinking about much more than the prevalence of disease or the biomedical treatment of disease. The Robert Wood Johnson Foundation has defined health equity in this way. They note health equity means that everyone has a fair and just opportunity to be as healthy as possible. And so following from this, health equity involves a broader perspective that encompasses medical and social determinants of health. And what we mean by that are things like poverty, discrimination, housing, and healthcare. And so with this goal in mind, Ann and I and our team, beginning in March 2020, started to gather perspectives from leaders from health systems, social service organizations, community-based organizations, and town and city governments across the bi-state region. And we had the privilege of speaking with people from across the bi-state region, including the North Country of New Hampshire, the Northeast Kingdom of Vermont, the Upper Valley, and the Windsor and Sullivan County areas. To date, we've conducted 50 interviews with stakeholders to document the early phase of the pandemic response across the region. In our interviews, we asked participants to describe their recent experiences with responding to COVID, to share what they were seeing and hearing with respect particularly to vulnerable members of their communities, as well as to reflect on their concerns and also to identify strengths and opportunities within their communities. And our goal in this work, we really hope to use these findings to help identify priorities for future research on the longer term impacts of the pandemic, as well as to inform action and policy to enhance rural health equity in the region. Marcos, could you advance the slide? Thank you. So when we launched the work in March of this year, the region, as we'll all recall, was bracing for an expected surge of COVID-19 cases. Many of us were worried that even a small number of cases could overwhelm the region's rural healthcare infrastructure. The region seemed especially vulnerable, given that we know rural communities are on average older and in poorer health than their urban counterparts. And many of our rural communities, particularly in the more remote and rural regions, have significant underlying social vulnerability. Adding to the concern, the region is a popular refuge for seasonal homes for those living in New York and the Boston metropolitan areas, which places northern New England at continued risk for overflow and resurgence. As we all know, thankfully, the expected surge did not occur in the spring. Yet despite having low overall numbers of COVID-19 cases, our work highlights how the pandemic has nevertheless profoundly impacted health systems and communities in the region. Moreover, the low rates of infection that we've seen mean that the region remains susceptible to COVID, which is especially concerning now in the context of efforts to reopen. Anne will now discuss our key findings in more detail, which illuminate some of the key challenges that we've documented, as well as how the pandemic has highlighted strengths within rural communities and new opportunities to address health equity. Anne?
Thank you, Elizabeth. So we have brought a health equity lens to bear on 5 different aspects of the early pandemic period. And I want to provide a high-level overview of our findings across these 5 areas. And my hope is that we can discuss them in greater detail in the breakout sessions that will follow. First, we began by looking at the pandemic response across the bi-state region from a health equity perspective. We know, as Elizabeth said, that small critical access hospitals and community health centers form the backbone of the health system in many rural areas. And many accounts have highlighted the fiscal challenges and fragility of these institutions. Our research showed, however, that although rural healthcare institutions operate with a small number of providers and more constrained resources, they were rapidly able to mount an effective response to the pandemic. Rural hospitals with very limited hospital and ICU beds were able to create critical care capacity, and primary care providers adapted practice rapidly to meet the dual needs of testing and treating patients while sustaining basic services. This response across the health system was facilitated by integrated networks bringing together health systems, actors, social service organizations, public health entities, and providers. Second, we're engaged in a national conversation about the vast inequities in the response to the COVID pandemic and in outcomes in medically and socially vulnerable populations. In our region, we saw that the protection of both medically and socially vulnerable populations was really central to the response. Across our research, we documented a wide range of efforts to protect the region's most vulnerable populations, including elders in nursing homes, individuals with chronic illness and behavioral challenges, and the homeless. Third, we sought to understand the implications of the rapid proliferation of telehealth for health equity in our region. In our region, telehealth emerged as a key tool for addressing persistent barriers to care for some rural populations. We can talk more about some of the nuances of these findings, including areas where telehealth was less effective in the breakout discussions that will follow. Fourth, we have talked a little bit about the ability of the health system to respond to the pandemic. But as we look ahead to the future, we heard consistent concern about the impacts of the pandemic on the long-term stability of the rural health landscape. Healthcare institutions sustained significant financial losses, and many worry about their ability to weather a prolonged pandemic period. At the same time, many across the region believe that the pandemic offers new opportunities to address policy and healthcare delivery challenges. We also sought to examine the impacts of the pandemic on the broader determinants of health and well-being. Our early data highlights significant and immediate challenges, including dramatic increases in unemployment and food insecurity. At the same time, the pandemic has revealed the resiliency of our local institutions and revitalized longstanding efforts to address many challenges, including housing insecurity, homelessness, and poor broadband coverage that limits opportunities for the region's most rural communities. Finally, our research illuminates a wide range of rural strengths, including the integration of health systems and other actors, the accountability and proximity of institutions to communities, and a protective rural ethos centered on compassion, solidarity, and pragmatism. While it may be difficult for us to quantify the protective impact of these strengths, I think it's essential that we highlight them as part of our overall findings. And I know that Sally and Faye are going to talk about some of these aspects in much more detail. Thank you.
Great. Thank you so much, Elizabeth and Anne. We're going to turn it over to Sally Kraft now.
Thank you very much. And Anne and Elizabeth, thank you for all that you've already taught us and opportunities for us to continue to learn as we go through these weeks of the pandemic. If you can advance the slide. You've heard Anne and Elizabeth talk about the health system and the community, and COVID-19 has led to changes so rapidly in the science and the practice of medicine. It's sometimes hard to believe that it's only been weeks since we have had to combat this virus. We have, in just a mere matter of weeks, identified testing. We've developed medicines and have tested medicines to help control the symptoms related to COVID-19. We have radically redesigned how the flow of patients move through hospitals, where patients who are infected are segregated from other patients, and have set up entire inpatient units and clinics and intensive care units to deal with patients who are infected with coronavirus. We've had to deal with massive national shortages related to personal protective equipment, and to learn innovative ways to restore and recycle some of that equipment. And many of you on this call have probably had the opportunity to experience a new way that healthcare is being delivered. That is with telehealth, as Anne and Elizabeth mentioned. Within just weeks, we have adopted and rapidly deployed the use of telehealth as a way to continue to provide clinical services to those people who we want to keep safe and sheltering in place, and also as a way to minimize the contact with the healthcare system so that we can conserve our personal protective equipment. But even if we get it all right in the healthcare system, it's not going to be enough to combat the impact of this disease on our communities. The long-term impacts of COVID-19 are going to require us to address all of those other determinants of health. You've heard them referred to as the social determinants of health or social drivers of health: housing, food, employment, access to transportation, access to childcare. And we have to address all of those determinants of health in order to really address this infectious disease. Next slide, please. So let me just tell you a story in 2 slides of what the Dartmouth-Hitchcock Health System Population Health Team has been doing in response to COVID-19. And this really represents many efforts across the entire Dartmouth-Hitchcock health system, but I'll summarize it as population health responses to COVID-19. The first thing is what I was talking about earlier. We really have transformed the delivery of clinical care, not only for patients who we are concerned who have COVID-19, who can get tested here at Dartmouth-Hitchcock, but those who may actually have the disease, or those who require ongoing care for either acute or chronic clinical conditions that we must be able to, and we are able to, provide those services in an environment that is free of virus and safe. And we've really radically redesigned the way we're delivering care in just a mere matter of weeks. The healthcare system is safe. You should feel confident when you go through the doors that you're able to receive services without the risk of contracting the virus. And that has been the product of many weeks of hard work. In addition, we said the knowledge and expertise that is housed within Dartmouth-Hitchcock, the only academic health system in the state of New Hampshire, should be spread freely to everyone around the region. It doesn't behoove us to hold on to that knowledge when others are suffering or need to learn how best to treat this disease, a brand new disease that none of us who have gone to medical school, even in the last couple of weeks, learned about coronavirus or COVID-19 disease. So we rapidly put together a panel of experts to disseminate knowledge and learning across the entire Northern New England region. And we have been hosting what are called Project Echoes. These are tele-learning opportunities for primary care providers, for community health workers, that very important role of the persons who are on the front line delivering support to patients as they shelter in place. We've provided education and learning for those who provide maternal care throughout Northern New England, and to employers who are working hard to keep their employees safe, their customers safe, and to try to restore some semblance of order to their business. So we hosted very rapidly these 4 ECHO courses. And finally, we know that in order for us to deal with COVID-19 in a holistic manner, we must create partnerships between health systems and community members. And we have been active in reaching out to those community organizations that many of you know well, who have been providing important services for years and years in our environment. And we said we have to work together very closely and to create a coordinated response to this disease. So we've convened with community partners across the region. We've provided staff to help get meetings underway, to provide the technology to support virtual meetings. And probably even more importantly, the Dartmouth-Hitchcock Philanthropy and Development Team within days said, how can we use the power of our philanthropic engine in order to raise money and invest deeply in the community organizations that are serving our patients, but also our brothers and our sisters and many of our populations across Northern New England. Next slide, please. So just to give you a flavor of what this means when a health system really puts its mind and its muscle behind being a good community partner. We have been partners in the Upper Valley Strong Coalition, which is over 50 community-based organizations, town leaders, government leaders, health systems, public health, all coming together to identify how we can best coordinate services across our region. We have been supporting the Greater Sullivan Strong Coalition, again, a coalition of over 35 government, not-for-profit, community-based organizations, health systems, all coming together to address needs in Greater Sullivan County. And we have been investing deeply in the Windsor County COVID-19 response team, as well as investments. And when I say investments, in this case, I mean financial investments in the Manchester Food Collaborative and the National Food Council. In order to restore health to us as individuals and to our communities, we need to look to innovative ways to work together. And those innovative ways will include partnerships between health systems and communities, because neither one alone is going to be able to control the impact from this disease. But together, I am certain that we can make a difference in the lives of our populations and the economic viability of our communities. Thank you.
Thank you so much, Sally. Next up, we have Faye Homan. And Faye, if you want to unmute.
I'm still learning the ropes, sorry.
It's all right.
So I'm a family physician in Wells River. That's about an hour north of Dartmouth, and it's a town of 350. So the rural perspective is, I think, what I'll be providing. And Marcos, you could go to the next slide. I have 3 slides, and I'm really mostly going to talk just about the second one. Just briefly, and this reflects a lot of what Sally was saying, I was really amazed at how quickly we came up with a response. When you think how long institutions often take to make decisions, we within 2 weeks had drive-through testing, had adequate protective gear, had geared up to do telehealth, phone medicine for many of our patients who couldn't do telehealth. All of the IT that required, the patient flow and keeping patients separate who did come into the office, and a lot of administrative time in trying to make all of these things work. And one of the most striking things to me was just how all of our employees really wanted to be involved, didn't want to be at home, wanted to continue with patient care. There just was a real ethic of service that permeated all the levels of employees at our organization, which was pretty great. So Marcus, you could do the next slide. But I think the bigger point or message that I'm taking away from this is that you know, in the early days of the pandemic, every message was, don't go to the ER if you think you're sick, don't go to the hospital if you think you're sick, stay home and call your primary care provider. And I think the pandemic response has really shown a spotlight on how important primary care is. There's been a lot of discussion about that in the last 10 or 15 years in healthcare policy, that if we have better primary care, we have better access to health, and it's less expensive and it's better quality. And it was really a spotlight was shown on it during the pandemic. It was a time when we really were motivated to save tertiary care and tertiary care resources for the sickest patients. And calling your primary care provider first turns out to be pretty good advice, even when you're not in a pandemic. It does raise questions about, do we have a workforce that's adequate enough to really be there for people? And that's one of my concerns, which is on the third slide. But likewise, during the pandemic response, when there was concern for needing surge facilities for people who didn't need hospitalization anymore, but were still perhaps infectious and not safe to go home, it was really primary care providers that they were looking for to staff those facilities. They wanted people who could do that broad scope of practice, all of the attendant health problems, not just the virus itself, and certainly not just tertiary care. During the pandemic, there's been a lot of discussion about advanced directives, which is something that we should all be taking a lot of care with in primary care anyway. But when suddenly the decision was, does this person need to leave a nursing home to go to a hospital? Would they rather stay in their nursing home even if they get sick? Can we keep them comfortable there? There was a lot of attention paid to that during the pandemic, which I think we should carry forward with us and remember when the pandemic settles down. And then this remarkable thing happened, and this was one of the positives, is that because the primary care docs and the specialists were no longer kind of locked into their fee-for-service, every slot on the schedule filled, cranking people in and out of your building, Because we had a little more breathing room and a little more time, there was just much better teamwork between primary care and specialty care. And I'll just tell a quick patient story about that. In the early days, I had a patient come in to the office with a bump on her tongue. I thought it was a malignancy. I was able to biopsy it in the office that day. Because the pathologists didn't have a lot to do, since there weren't a lot of surgeries, I got results on the biopsy within 36 hours. It's just unheard of. It's usually 2 weeks. And spoke with the ear, nose, and throat surgeon the same day at Dartmouth, was able to discuss with him which imaging we needed before he saw her, some pain management strategies in her particular situation. And she saw him within a few days, had her surgery and her treatment plan completely finished within about 2 weeks. That would never happen in the real world. That would be a 2-month process. But because of COVID, because we weren't sort of locked into that hamster wheel of cranking patients in and out, there was some really, really great patient care and communication that was able to happen. So Marcos, you could put on the last slide. I'm not going to go through this in detail, but I think there's so much to talk about here. Do we have enough primary care providers to really do the next pandemic or the next wave? What's going to happen as our aging primary care workforce ages out, because it's really quite an older workforce. And financial stability of our clinics, especially the private practices, is a big one. I think we are going to see consequences of delayed care. I'm already beginning to see that in my office, people who stayed out for all those months. And in particular in our office, what we've heard a lot from we have a MAP program, so a Suboxone program for people with opiate addiction. And those people have not had their group meetings and their support meetings, and they're really asking for that. So some of the consequences of this are going to be showing up a little more down the road. I have tons more I could say, but I'll end there. Thank you.
Thank you so much, Faye. Well, now we're going to break up into small groups for about 15 minutes. When you get into your small group, spend about 30 seconds each introducing yourself and what brought you here today. Pick someone to take some notes or a reporter. And we're going to have 3 different questions to help guide your conversation today. The first is, what brought you to this event? What is your experience? In your experience, how is COVID-19 impacting access to health resources in your community? And what questions do you have about what the panelists presented this afternoon? So we'll come back after about 15 minutes, and your group will have the chance to pose some questions in the panel. All right, so without further ado, I'm going to ask our moderator here to move us over into small groups. What will happen is your screen might go blank for just a moment. You'll see a little boop, 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 boop symbol, and then you'll pop up into a much smaller group with about 5 or 6 people. We also have the questions in the chat. So thank you, Aurora, for posting those today. I appreciate that. Hi, everybody. Looks like we're back in our large group session. We're in a good conversation in our group. I always get to say that the benefit of having me in your group is that I get to ask some of the first questions. Again, in your chat, if you want to jot down some notes that were occurring in your room and specific questions that you might have had for the presenters who spoke, please put them into the side, and either myself or Aurora Drew will chime in with some of those questions. Sometimes we get so many that we need 2 or 3 eyes looking at them. We do try to answer any question that we get with the time allotted, but we're only about 15 minutes. So I'm just gonna look around the room, make sure I've got some of our speakers on there. One of the key things that we chatted about in our group was rural communities' ability to locally communicate and disseminate information at a rapid response. And Anna was able to give us a good overview about that. But I would be curious to hear from the other panelists about their thoughts on how local communities can communicate public health, or what are some ways or innovative ways that you're seeing local communities communicating about health issues that are happening right now during the COVID-19 pandemic. I'd throw that up to any of the speakers.
This is Bob. I live in Norwich, Vermont, and many of you live in the community. And one of the things that I've really been struck by is the Norwich Listserv, and in particular, the postings that come from the police, chief of police, and also from Dan and Witt's, you know, the local general store. And it's really interesting for me that, you know, these are, you know, daily messages that come out from, you know, from both of these community leaders. And they're not coming from the health system. They're coming from a guy who owns the general store, Dan. And his messages are spot on about caring for neighbors, about delivering food, about chipping in money. He really sort of covers all the big issues that are out there, well, most of them, not all of them. And I've really just been struck that, you know, here's community at its very best. And we have Jen, who's the chief of police, who's giving us updates. And the listserv has really served as a forum for questions and opinions and thoughts. It's really cool.
Thanks, Bob. That is an interesting ruralness, right? That many of our communities, at least in the Upper Valley, still operate with communication through a listserv, which is not necessarily true of like every region in Vermont, New Hampshire. I'm curious if our researchers or other folks have been thinking about how local health systems communicate with the listserv. I know it's something that we use quite often to promote and discuss, you know, public access to science. So any other thoughts on that from any of the presenters?
Thanks, Bob. Just to build on what you're saying, I mean, I think that, you know, that's one of the really unique strengths of being in small scale environments like this, is that, you know, that kind of everybody knows everybody, or what we might think of even as a kind of village mentality exists here. And so it's something that we, you know, whether that's through anchor institutions like the general store or other trusted leaders in our small communities, there's really the ability to have very effective outreach. So that's, you know, what we've seen in the more informal side of things. But it's also the case, and I really want to point out that, you know, and Sally can certainly speak to this in more detail, is that a lot of the effective outreach has really also, the foundation of that has really been these more formalized networks and coalitions across the region as well, that are formal partnerships between health systems, social service organizations, community-based organizations, and mutual aid. And so this is something that has really facilitated the ability for communities to rapidly respond, and respond in a very protective way, particularly for the most vulnerable community members as well. So it's, I think we're positioned extremely well in our region, given both, I think, a strong network of more informal communication and care, but also very much in the more formalized sector as well.
So that's you know, we've been hearing about some, you know, positives that have come in there, and I'm a little more curious about some of the challenges that, you know, that have brought up there, you know, have been brought up right now about rural environments and health equity, especially when we think about the term equity. Like, have you been, you know, communication and sharing the information is one way of thinking about getting out information equitably, but that said, you know, has service been equitable throughout the rural regions, and your findings? I guess I'll throw that to Elizabeth or to Anne. I don't know. Like,
I was just going to mention, in terms of equity, I mentioned this in our breakout group, is just access to telehealth, access to broadband is a huge challenge for our patients. There's great swaths of area around us where that's not possible.
Yeah, I wanted to follow up and say that one of the things that we observed was that there were extraordinary efforts on the part of primary care providers and social service organizations to reach the populations that were already connected. But one of the things that the pandemic highlighted is that there are large numbers of people that are not already medically homed or connected to an institution, and that's where the real concerns emerged across the region. So we heard many people talk about their concern for those that were not being identified or that were not part of their patient census and what was in place for them. That said, we also heard a lot of accounts of efforts to reach out through the informal and the formal networks that existed.
So I think that's interesting that, here's an external factor that you've mentioned, broadband, right? Broadband is something that is an external factor that plays a role in rural health equity. Were there other external factors that, like economic weather, or other things that actually inhibit creating a more equitable space for health resources here in the States?
Transportation consistently rises to the top when we think about health equity in rural regions. That's been mitigated somewhat in the pandemic by virtue of telehealth, but it's also the case that we've heard accounts of concern about access to resources due to limited transportation, and in particular related to food security. And so that's something that we know to keep an eye on moving forward as a really key barrier that limits people's access to various forms of support and resources.
I would also follow up and add that housing insecurity emerged as a key concern around the pandemic. There were a lot of people across our region that were not categorized as homeless. They were doubled up or living in really insecure housing. And then with the concerns around infection, a lot of people were quickly pushed out of insecure situations. And many of the providers across the region said that this allowed us to have allowed them to have their first census of that population to really think about those interventions. But it became a concern pretty quickly right now. And we know that housing has important implications for health, or is one of the key social determinants of health.
One of the things that Faye brought up in our small group was culture, and the Yankee sort of self-sufficient culture sometimes creates some barriers in terms of reaching out and saying, I need help. So I thought that was a really an interesting observation that in this time when it's really, we're all talking about trying to connect and create this web of connection to take care of each other, especially those who are socially isolated, that culture of Yankee self-sufficiency can be really a barrier to caring for each other.
Oh, go ahead. Yes.
Well, I was just thinking of two other things that seem to be barriers to me. One, it kind of meshes with what Ann said about housing, is that even though we're trying to do telehealth, and actually in our organization, a lot of behavioral health, mental health counseling remotely, people with poor housing situations have no privacy, and they're not really able to engage in a conversation with their counselor when there's 9 people living in the house. And so that is a disparity that became apparent to me. And the other is just fear of getting health care. And so we saw a really sad case of someone who could easily have gotten, been helped early on, who just was so afraid to go to the emergency room because she'd heard about COVID and thought she would catch it there, that she ended up much, much sicker than she needed to be. So there were a lot of those sorts of things. And I don't know if fear is exactly an external factor, but kind of getting the education and the understanding correct and out there would be helpful.
Yeah, I was actually curious about, and I would posit here into the term of like accessibility, and it seems like there are a lot of external factors like transportation is an accessibility issue that many people are having, but also what does it feel like to now go into a medical environment, and what is the buildup that one is seeing from the news or from just general talk about wanting to even approach or go to your GP. I think I will credit DH for messaging numerous times via text, email, and personal phone calls that it is okay to go in for simple procedures or blood draws or regular procedures, especially after that first month. We had a nice comment in the chat from a colleague in West Virginia who's also experiencing a similar experience of self-sufficiency, really thinking about strength in rural residents. We have a few minutes remaining here, and the sort of Yankee I can do it myself might have also been sort of noted under 3 terms that I heard from our initial presenters talk about: compassion, solidarity, and pragmatism. And I'm just wondering if you could define those terms a little bit more for us. Those are very thick words. So how do those manifest on some of the on-the-ground things that you're seeing?
Sure. So, Marcus, this is what we're using to describe what, I think could be glossed as, rural culture, rural ethos. And, it's kind of this really interesting intersection of, both there was a very efficient response, a very rapid response, but also a response that was very, that was rooted in care, and was also deeply thoughtful. And so as we think about kind of that notion of, compassion and pragmatism, but also that sense of solidarity that we're seeing certainly, in broader conversations outside of the region with respect to we're all in this together. I think that will be something that, we hope can be sustained over time, because I agree with the strong forms of individualism that we see, particularly in Northern New England, may certainly pose a barrier moving forward. But I'm hopeful that we can build on this moment, of solidarity that we're seeing.
Great. Thank you so much for that response. I'm going to leave it. We have about just 1 or 2 minutes left, but if nobody has any further questions, I'll give it 1 second of breathing room here for someone to dash something in a chat. I'm not seeing that. So I'm going to say that this has been a real pleasure to hear from all of you and to talk about these issues with folks in small groups. Thank you, Anne, Elizabeth, Sally, and Faye. Thank you, everyone, for attending today's session. I think we've learned a lot. Everyone who pre-registered for this program will receive a follow-up email with a link for a survey. I'm going to put it up in the chat right now, though, so if you want to fill that survey out just before you leave, that's great. We're always trying to improve our Health Research Live programs. We look forward to having another one soon, so stay tuned to our various channels, and we'll let you know when our next one is. And without further ado, thank you so much, everybody. Feel free to sign off. We're gonna stay on the line for just a little bit longer if people want to click that survey. But wonderful seeing everybody from the community and talking about these very important issues. Thank you.